A stroke healthcare practitioner approach to code strokes. First disclaimer. The material presented here is only presented as an opinion for educational purposes. For the full management of the acute stroke patient, refer to the latest guidelines and other authoritative sources of information. The material presented here is in no way intended or be used to bypass or override your opinion, criteria, advice, guidance, or that of your stroke expert. It is expected that there will be differences in opinions, approaches, and practices. The one presented here is only one of them. What's expressed here is subject to change, including having to individualize as the situation merits it. See additional disclaimer in the description, under 4.5 and under 24 hours. Acute stroke symptoms, in their first 24 hours, are an emergency. There are two treatment approaches: intravenous thrombolysis, or IVT, within the first 4.5 hours from onset, and endovascular therapy, or ET, within the first 24 hours from onset. In the first 4.5 hours, both treatments may be indicated. But, which are the steps that a stroke healthcare provider should take to successfully and timely take care of this complex situation, and levels of parallel and serial information pieces that needs to be obtained, amassed, and interpreted to go from activation of the code stroke to thoughtful therapeutic decisions and approach. Yet, the actual outline of the paths to manage such emergencies are passed from one generation to another, mostly by example and bedside teaching, and as far as I know, there is no step-by-step outline approach. Here is an approach, my attempt at helping with this perceived gap. The steps in a code stroke in the first 24 hours needs to be deliberate, organized, methodic. These steps include fluidly communicating with the different members of the team as information arrives and as decisions are made. The patient should only get the tests she needs. Sometimes CT angiograms and CT perfusions may be necessary, but not in all code strokes. The patient should only be exposed to the lowest amount of radiation and contrast that leads to the maximal diagnostic yield. Doing more tests may actually decrease the diagnostic yield or return on investment, or ROI. Always ask yourself, in retrospect, was this or that test needed? How can I apply this lesson to future cases? Stroke symptoms without a known or clear less known in usual state of health or lacush, such as wake-up strokes, may need to be run as code strokes and considered for endovascular therapy if criteria are met for such. The patient. The main character and the star of the process is the patient, and the rest with empathy, respect, patience, and candor. They need to be updated of the process and at intervals during the stressful and fast-paced process of the code stroke, the team on the ground. As the HCP running the code stroke, it is imperative that you be aware of all the members of the team involved and what their mission in the process is. It helps a lot if you know their names too. Be kind, confident, and personable. It is imperative that we answer the call page message about the code stroke as soon as possible, in under 5 minutes. Know who is on call and how to contact the neurointerventional or NI team. You be ready to review the initial CT scan yourself. If under 4.5 hours and symptoms are disabling, then consider intravenous therapy such as tenecteplase, and if patient is a candidate, then stop at this step to deliver the intravenous therapy. If the NIH stroke scale is 6 or higher and time is under 24 hours and modified Rankin score 3 or under and suspected large artery occlusion or LAO defined as pre-M3s and pre-P2s, and if the patient is candidate for endovascular therapy, then get CT angiogram. If there is confirmation of large artery occlusion, then get CT perfusion. You are ready to review CT angiograms and/or CT perfusion as soon as they are done. Prepare to discuss with neurointerventional. If renal function is borderline or the patient has had recent contrast load, then consider performing CT perfusion, which uses about 45 milliliters first, and only proceed to CT angiograms, which uses about 90 milliliters of contrast. If there is a pattern for large artery occlusion, with criteria for endovascular therapy, such as NIH stroke scale of 6 or greater, large penumbra, under 50% core, etc. In other words, if the CT perfusion is normal, then there may be no indication for acute CT angiograms, and you avoided using more contrast. 3. Practical ifs. If the patient is not a candidate for intravenous thrombolysis, then let the pharmacist know so they can leave and continue their regular work. If the patient is not a candidate for endovascular therapy, then let the angiography suite personnel know so they can leave and continue with their regular work. If the patient is a candidate for intravenous thrombolysis or endovascular therapy, then let the pharmacist and/or angiography suite know so they can activate their processes to deliver the corresponding therapy. Or at least let them know that you are still making the decision, as you may need to discuss with neurointerventional. If there is acute bleed in the CT, is it intracerebral or ICH, or extracerebral and/or intraventricular? Intraparenchymal hemorrhages are managed by neurology. They are medical conditions. Only in very few occasions is neurosurgery needed. Extraparenchymal bleeds, such as subarachnoid hemorrhages, subdural or epidural hemorrhages, will be managed by neurosurgery. There may be a need for CT angiograms if there is a neurismal pattern of SAH, suspect venous thrombosis, or if it looks atypical. If there is acute bleed, you will not need CT perfusion. Make sure that you update the patient and family as you go. If the patient is going to get intravenous therapy, then you may need to get verbal informed consent. Keeping track of times. Most common stroke mimics. Functional. About 1 in 7 acute stroke presentations. Delirium. Recrudescence of prior strokes, seizures, migraines, and dysglycemia, among others. 12. Key data pieces to obtain. Last known and usual state of health or last known and usual state of health. The NIH stroke score. Is the stroke disabling? Is it under 5? Is it 6 or higher? The modified Rankin score. Is it 3 or greater? The vital signs. Blood pressure, pulse oximetry, heart rate, temperature, and others. The glycemia. Is it between 60 and 400? Is the patient anticoagulant use? Is the INR under 1.7? Any recent lumbar or arterial punctures in the last 7 days? Any major surgery or trauma in the last 14 days? Genitourinary bleed in the last 21 days? And traumatic brain injury or any neurosurgery in the last 90 days? What is the code status? What is the hematocrit and the platelet count? What is the most recent creatinine BUN? Is the patient making urine, anuric, or on dialysis? Does the patient have contrast allergy? The team on the ground, responding to the code stroke, and with you will a number of people looking to helping the patient and you, and these include the bedside or emergency room nurses, the rapid response nurses, the CT technicians, the pharmacist, phlebotomist, the angiography suite personnel, the neurointerventional physician who may be on the phone, the primary and ED physicians, the stroke center coordinator, and even residents and students. Some of the times to keep track of and document include: get the first code stroke call? When did you call back? When did you arrive to bedside? When did you see the first CT scan? When did you give the order for or against intravenous thrombolysis? If the patient is an endovascular therapy candidate, when did you call the neurointerventionalist? When did you talk and updated the patient and family? When did you talk to the primary or emergency room team about the decisions? When did you obtain the NIH stroke score, the modified Rankin score, the ABCD2 in transient ischemic attacks, or the intracerebral hemorrhage score? Thank you. Presentation will be useful. If so, please consider sharing it so that others can benefit from it. In the description below, download Acute Stroke Tool, some pertinent additional information, and find the disclaimer.